Hello, I'm Dr. Helane Fronek, and it's a pleasure to welcome Dr. Lowell Kabnick. Lowell, you're a vascular surgeon, and I know that you've been treating vein disorders for a long time. How have you seen the surgical treatment of vein disorders change over that period of time?
Gee, I've been involved in surgical treatment for about 30 years, and we've seen it change drastically for the better. It's more patient-friendly, and the procedures are more physician-friendly. So we've gone from something like stripping, which has been really equated to medieval torture at this point, to really these endothermal procedures or these heat procedures, which work really well for the patient with an ease of recovery.
So I bet patients are a lot happier nowadays.
Oh, clearly. Their satisfaction scores are really high. People that had stripping before have horror stories. They don't want to come in and see us anymore. And now that they've heard about these newer procedures, they understand that there's a treatment that is really patient-friendly and that they can have the procedures done and they can go back to work or recover very quickly.
You know, one of the procedures that we do nowadays is something called phlebectomy, which sometimes people refer to as mini-stripping. How does phlebectomy differ from real stripping?
Well, stripping involves a couple of incisions and an instrument that goes through the vein, and then you pull it out like a lawnmower. When we do microphlebectomy or ambulatory phlebectomy, we basically make a little pinhole, and with a hook that looks similar to a crochet hook, we tease the vein out through a little small puncture. We don't use any stitches. We use like little butterflies, or some people don't use anything. And then the recovery is much, much easier. There are no suture marks. There are no staple marks. So we've really progressed in this field in terms of this procedure.
That's a huge advance. I know that before, when people would have stripping done, they would be in the hospital. They would use a general anesthetic. How does phlebectomy or mini-stripping or microphlebectomy differ from that?
Well, when I first started, we had patients in the hospital for a week. They were at bed rest. And now we do these procedures in the office under local anesthesia with essentially they can resume activities of daily living right from the get-go. So it's really changed a lot, and it's made it very much easier for the patients.
Can you treat every vein with phlebectomy?
I think you need to look at the patient, understand what their vein problems are, and then select the best procedure for the patient. And there are many variables that go into this. So most phlebologists have the armamentarium to be able to treat all of these with different procedures. So we're, again, selective depending upon what it is that the problem occurs.
And so which vein in particular, or what type of vein would you select for phlebectomy?
For phlebectomy, we usually choose the veins that you visually see, that you actually, patients actually come in and say, oh, gee, I've got this ropey vein that I can see. It's above the skin, it's gnarly looking, and I just want it out. And those are the type of veins that really lend themselves very well.
Gnarly is a great adjective to describe those veins. I like that a lot. They are really gnarly. What are the advantages of using phlebectomy versus some of the other treatments such as sclerotherapy?
With phlebectomy, and I tell my patients, yes, we could treat this big, huge, ropey vein with sclerotherapy, but the time of which it's going to take to cure, in other words, to get the same result as you do with phlebectomy, takes much longer. So phlebectomy, you remove the vein, the incisions heal or punctures heal, or as I call it, pinholes, heal very quickly. Within a matter of days, you can hardly see it. And then in terms of the black and blues that you get, those pretty much go away in a couple of weeks. With sclerotherapy or injection of chemical into those veins, usually in about 2 to 3 weeks, you have to come back and you have to express some of the trapped blood that's in there, because that can then tend to make the patient have this brownish discoloration, which they really don't like. And then you have to basically wait for several weeks or even months to achieve the same effect that you can with phlebectomy.
Okay, so it sounds like a much better procedure for those gnarly veins.
There you go.
Yeah.
For those gnarly veins, we like to do phlebectomy as opposed to sclerotherapy. But there are veins that tend to go for sclerotherapy.
Okay. I know that you treat the whole gamut of vein disease. So What about the little spider veins or those bluish veins we call reticular veins? Is that the type of vein that you would treat with sclerotherapy?
Yes, absolutely. Those are the veins that lend themselves for injection of chemical, which essentially then destroys the vein wall and the veins eventually collapse. So depending upon the size of the vein, depends upon really whether we use sclerotherapy or phlebectomy. So for the spider veins, as you mentioned, or the reticular veins, which are those blue veins that we see, that really lends itself well to sclerotherapy or injection of chemical.
Okay. Going along with that whole gamut, I guess the opposite end of that would be the patients who have open sores or ulcers on their legs. Is that what you would say?
Yes, absolutely. In the beginning, you may see some spider veins, reticular veins, or even some varicose veins. But at the end of the spectrum, as you say, there are these skin sores or really painful ulcers that develop. But there is a gradation between something like spider veins all the way to ulcers. So you can really follow the progression of the venous disease looking at the patient, and they just don't start with ulcers as a rule.
So what are you actually looking for? If a patient were to come to see you, what would you look for that would tell you that they were going to develop an ulcer at some point?
We look for advanced changes. We look for brownish discoloration. We look for hardening of the skin areas. We look for patients that actually have had a little nick in their vein that bleed, and sometimes it's rather profuse or a lot. And then there's that progression from there to the skin starting to change into a whitish discoloration, and then to a frank ulcer.
Okay.
And by that time, the patient is really way down the road, and a lot of this can be halted in terms of progression with what phlebologists do in terms of their practice. So, you know, patients usually come to me and they say, you know, my physician basically said, hey, you know, this is really not important to you. This is mostly cosmetic. And then they come with these ulcers. And I said, what happened? He said, well, nobody really told me anything that could be done. Nobody told me about conservative management with graduated compression hose. Nobody looked at my veins in terms of what we talked about, large veins having reflux or blood going down the leg instead of back to the heart, where it adds distension in your veins and pressure. Nobody told me about this. Nobody seemed to have known. And thank you that the phlebologists are now involved in this, and you can help us. And they really feel really better about it. And then we see those patients, and it runs in families. So these patients that have ulcers, we're tending to see advanced disease in some of their offspring, and we then educate them to understand what's going on, and then they transmit that to their children, and that's wonderful.
So it really sounds like education is the name of the game. We need to educate physicians so that they don't say to their patients, if your veins don't hurt, you don't need to do anything about them. And then phlebologists also educate their patients.
Correct.
But these ulcers, they're usually pretty painful, aren't they?
They can be very painful, and they can certainly take the patient out of the workplace. They've cost, in terms of treatment and in terms of downtime, lots of money to insurance companies, the government, employers' downtime with these patients, and they really can be helped. So we look at these in terms of two different types of treatment. First one we look at is conservative management, and that's using graduated compression hose, leg elevation, skin care, proper nutrition, and actually evaluating what they're doing. If they're sitting at a desk for any period of time, or they're standing in place, we ask them to move to simulate a walking motion.
And then I would bet that exercise is an important thing also to recommend to patients.
Correct.
Okay.
That makes for healthier veins.
And so if you see a patient who comes in with, let's say, those brown spots around their ankles, and you can tell that they're starting to move in the direction of developing an ulcer, then those are the patients who a phlebologist can treat and prevent an ulcer. Is that right?
They can certainly decrease the chances of getting an ulcer. And they would normally evaluate the patient, look at the ultrasound to see the pathology, and then treat it accordingly.
Well, that is great, because if we could prevent ulcers and all the disability and suffering that comes with it, that would be a great thing for patients.
If we could reduce the ulcer rate by 50%, we would be really doing wonderful. And that is a goal.
That is a great message. Well, I really want to thank you for coming in. You've covered the whole gamut of vein disease, from spider vein sclerotherapy to treatment of varicose veins, and then to evaluation and prevention of ulcers. So thank you so much for taking the time to talk to us.
Thank you, Helane. It's been a pleasure.